And we're going to keep looking at patients in a case-based format because I think application of these interventions in this case-based format is probably the best way to really help understand when we employ different techniques. So this is Blixa, and she's a very nice bull terrier, and you can see that she has her IV in before she was pre-medicated. She's standing there, she's panting, she looks fully awake. She's a very nice bull terrier. She wants to be touched and scratched and very compliant, nice quiet dog. Her mouth is open about as wide as her jaw angle will open, and so that's going to make it difficult to intubate her. And bull terriers, I don't want to say more often than not, but frequently, or I love the phrase, not uncommon. So every once in a while, a bull terrier will come in and their jaw angle is very narrow. Their TMJ joint just won't open particularly wide, and I'll have to use it over the stylet technique to intubate these bull terriers, or their pharynx seems to be calcified or at least have very dense fibrous tissue where it's very difficult to push the tip of the epiglottis down with the laryngoscope to even visualize the arytenoid cartilages during intubation. And Blixa, I know, is going to have a little bit of a difficult intubation because her jaw angle is not particularly wide. So she came in just for oral exam and dental cleaning. We're not exactly sure if there's anything in particular going on in there. During her physical exam, it was really unremarkable. Her teeth were relatively clean. I'm anticipating that this will just be oral exam, x-rays, and a nice cleaning. Of course, after intubation. Her pre-anesthetic laboratory testing is all within normal limits except alk phos is elevated at 402 milligrams per deciliter. Is that a concern? No, it's not a concern. It's not crazy high, and alk phos isn't really indicative of anything in particular that's specific for a disease process. It's inflammation that cells in the body have been damaged in some way. Life damages our cells. So when it's just a little bit elevated like this, I'm not concerned that she has Cushing's or that she has another problem going on. Certainly, there's no indication that she would have a liver issue or anything else that would make alkaline phosphatase very, very high. So she goes to sleep. She actually was relatively easy to intubate without the stylet, just on inspection of her larynx. I had good visualization of her arytenoid cartilages. The tip of her epiglottis pushed down very nicely with the laryngoscope. And here she is asleep. And her first set of values, her end tidal CO2 is 64. You go, is that too high? Is it too low? Or is it acceptable? I go, that's too high. So when we talk about acceptable range under anesthesia, normal is 35 to 45. And when we're awake, our carbon dioxide is held very tightly between 35 and 45 because, remember, it contributes significantly to acid-base regulation. So hers is 64. So it's crossed that threshold where now she is becoming acidemic enough to start to influence her enzymatic processes and her ion pumps. So at 64, we go, she is hypercapnic. We go, her respiratory rate is 2. We can look at the number and go, that seems very, very low. She's hypercapnic, so she is hypoventilating. We want to help her by either giving her a few manual breaths, and then also, what's the first intervention? Lower the anesthetic inhalant concentration. First intervention. So we look at that and we go, we're going to lower the inhalant concentration. Let's continue through the values. So her systolic pressure is 77. Her diastolic is 35. And her mean is 40. So she is globally hypotensive after induction. The disparity between systolic and diastolic, though, is about 40 millimeters of mercury, which is about the correct disparity between the two values. You look at that heart rate of 59 and go, that seems like a low heart rate. I would almost expect diastolic hypotension to be occurring with a heart rate of 59. Well, all of her pressure is so low. It's really hard to get diastolics of 20 or 0. So it's about as low as it's going to go, and so the influence of heart rate is influencing blood pressure likely globally, not just the diastolic pressure. So global hypotension. So she probably has a little bit of vasodilation, but we've just started the inhalant.